The topic of discussion that we are going to have right now is about tubercular pericarditis. So in this lecture, we'll be talking about clinical feature, we'll be talking about examinations, we'll be talking about different investigation that we do to find out tuberculosis pericarditis. Similarly, we'll know about complication or sequels of this disease. So, and at last, we will be correlating its heart sound with other sounds also. So without delay, let's begin our discussion. So talking about the clinical feature of tubercular pericarditis. Okay, TB, the typical feature of TB. What are the typical feature of TB? These are night sweats, low grade fever, right? That's especially evening rise of temperature, and involuntary weight loss. That is what about decrease in 5% of weight, or we can say, right, according to UK, we can say about 10 pounds, right? LBS 10 pounds, okay, over 6 months. So clinical features, and there is one clinical feature that is important, that is chest pain at rest. Since it is related with pericarditis, so chest pain is typical it is feature of tubercular pericarditis. So chest pain, night sweat, low grade fever, evening rise of temperature, involuntary weight loss, decrease in 5% of weight over 6 months. These are the features of our tubercular pericarditis. Now on examination, the thing that we do is we auscultate, right? What are the auscultatory finding? The auscultatory finding is pericardial friction rub. Now pericardial friction rub, why we hear pericardial friction rub? It is hard because of inflammation between outermost layer of heart and, right, and because of which there is serofibrinous exudate. Because of that we hear pericardial friction rub. Now this pericardial friction rub can be confused with another thing, and that is pleural rub, right? Pleural rub. Now if you look carefully, pericardial friction rub, it is heart originated, right? Heart originated, the pericardium, the outermost layer of heart, it is originated from outermost layer of heart. But talking about pleural rub, it is lungs originated. That means pericardial friction rub has nothing to do with our breath. So this pericardial friction rub is it is persistent on holding breath also. But talking about this pleural rub, it is not hard on holding breath, since it is related to lungs. So if we are not breathing at the time, we are able to hear pericardial friction rub, because it has nothing to do with lungs, right? It is originated from pericardium of heart. But talking about pleural rub, it is originated from lungs. So on holding breath, it is not hard, right? It is not hard, or we can say on taking deep inspiration, it is best hard, pleural rub. So breath holding is the best method to differentiate between these two. What are these two? Pericardial friction rub and pleural rub. So on holding breath, we can hear pericardial friction rub, not pleural rub. So this is the best way. Breath holding is the best way or technique to differentiate these two things. And talking about investigation, what are the different investigation that we do? The first is our ECG finding, and in this ECG finding, what we will find is we will find ST segment elevation, right? What we will find? We'll find ST segment elevation. You can see PQRST, right? Okay, this is our ST elevation. Now this ST elevation is there is ST elevation, as you can see, it is elevated. And talking about one special feature, that this ST segment is concave upward. As you can see, it is concave it is concave upward. Similarly, there is another condition, that is myocardial infarction, in which there is ST elevation, right? There is ST elevation, but in the case of myocardial infarction, the ST elevation is convex upward. As you can see right here, it is it is convex upward, right? Convex upward. Okay. And talking about acute pericarditis, right? Acute pericarditis means it is spread. It is spread everywhere, right? It has spread everywhere. So 11 out of 12 lead are having ST elevation except AVR, right? Why AVR? Except AVR, because it shows reciprocal change of ST, right? ST segment, that is ST depression. Okay. In normal person, P wave and T wave are always upside down. So, right, the reciprocal change of ST segment is found in AVR, right? AVR, there is everything, we find everything reciprocal right here in the case of AVR. So in the lead AVR, what we find is we find depression of ST segment. That is one important thing that we need to keep in our mind. As you can see right here, right, we can see inverted P, we can see inverted depressed ST segment. Okay. Now we talked about ECG finding. Now what about other finding? When talking about echocardiography, right, we find minimal pericardial effusion. Why we find minimum pericardial effusion? Okay, if we just recall our fact, then in between different layer, right, in between the layer of pericardium, we find about 20 to 50 ml of what fluid for what, for making it frictionless, right, for facilitating for lubricating it. But in the case of what, in the case of tubercular pericarditis, there is what, there is inflammatory cells also, right, there are inflammatory cells also. Because of these inflammatory cells, there is what, there is slight increase in volume of that fluid. That means it will be more than 50 ml, right. So there is minimal pericardial effusion, minimum pericardial effusion. Okay, talking about CVNAT or gene export report, right. Okay, and okay, talking about this pericardial fluid. This pericardial fluid can be measured with the help of what, it can be studied with the help of CVNAT, or it is also called what, our gene export. Now these are what, these are our investigation, right, our finding. Okay, now talking about what, the complication of this condition, and talking about the complication of our this constructive pericarditis, right. Okay, since the person is suffering from tuberculosis pericarditis, we are what, we are treating it with what, our tubercular regime, right, for 6 months. Now on the process of treating this tubercular pericarditis, what will happen is that there will be formation of calcification. That means egg like cell. Okay, what is this? This is our what, pericardium, right. Outside this pericardium, if you will see carefully, there is what, yellow layer, right. Now this yellow layer, what is this? This is our calcification. Calcification, that is egg like cell develops around the heart of person, which limit the feeling of heart from outside. Okay, for example, this is what, this is our heart feeling, right, heart feeling. In normal condition, this is normal individual, right. In the case of normal individual, what will happen is that as blood will enter into what, into our heart, and this blood will cause what, pushing, right, this blood will cause what, ventricle to dilate, or there is compliance, right, compliance. But as the person is in phase of getting treatment of this pericardial tuberculosis, at this time what will happen, there will be external egg like cell, right, egg cell like structure outside this pericardium, because of which there will be no dilation, right, there will be no dilation. As there will be no dilation, the blood that is going right here, right, striking on this wall will again bounce back, because of which there will be what, turbulence, right, there will be formation of turbulence. So because of this turbulence, during auscultatory finding, what we find is, we find pericardial shudder, right, pericardial shudder. That means as the blood will go here, it will strike and it will again bounce back, because of which there will be turbulence, right, turbulence will be there, and this will be heard as pericardial shudder, or it is also called pericardial shock or pericardial knock. So this is what, this is auscultatory finding. So it is what, such type of sound is heard during auscultation. So this is the case of what, pericardial constructive pericarditis. So the person suffering from what, tubercular pericarditis, during the time of treatment, what will happen, there can be calcification about around pericardium, which will result auscultatory finding, that is pericardial shudder, pericardial shock, or pericardial knock. So that's all. So now talking about this pericardial what, pericardial shudder, right, pericardial shudder is what, it is seen together, it is seen along with what, it is seen at the time of what, at the time of feeling, right, at the time of feeling. That means at the time in which mitral valve is what, opening, right, opening, mitral valve is opening. And if you recall the fact, then how many heart sound we studied previously? S1, right, S2, S3, S4, right, S4. And there was ejection click. Ejection click was because of what, opening of our aortic and pulmonary valve. There was opening snap. Opening snap was because of mitral valve and tricuspid valve, right. So that means here there is filling of blood into ventricles, and this filling of blood into ventricle will occur after opening of mitral valve, right, after opening of mitral valve and tricuspid valve. So that means after opening snap, right, after opening snap, there is what, there is our S3 sound, right, S3 sound during the time of ventricular filling. So this S3 sound, what, it collides, it overlaps with what, our these what, pericardial knock or pericardial shudder. So this pericardial shudder and S3 sound, they are overlapping each other. But what is the best way to differentiate these two sound? As you have already mentioned, there are how many, 3 what, low pitch sound, right, low pitch sound. How many are there? There are 3. What are 3? S3, S4, and the sound that we heard during the time of atrial myxoma, right? Atrial tumor plop sound, that is what, that is our tumor plop sound. So these are only what, tumor plop sound, these are only the low pitch sound, and these are heard with the help of what, with the help of bill of stethoscope. But talking about this P order, right, pericardial order, it is what, it is high pitch sound. So this sound is heard with the help of diaphragm of our what, diaphragm of our stethoscope. So this P order sound, this pericardial order or pericardial knock or pericardial shock, it is heard with the help of diaphragm of stethoscope, whereas S3 is heard with the help of bill of stethoscope. So in this way we can differentiate, or we can find out there is pericardial order or not. So this is what, this was a brief about what. Okay, let's again recall it. What is there? There is S1 sound because of closure of mitral and tricuspid valve, and then there is ejection click because of what, because of what, our opening of what, opening of our aortic and pulmonary valve. And just after ejection click, what we can find? We can find mid systolic click, and this is not normal finding, it is found in the case of mitral valve prolapse. And after that we will find S2. Now what is this S2? This is the sound that is heard, right, after the closure of aortic and pulmonary valve. And this duration is what, this duration is our, okay, from S1 to S2, this is systolic phase. And from this S2, after this S2, right, now there is what, there is opening snap because of mitral valve what, or tricuspid valve opening, and this will overlap with tumor plop sound that is heard in the case of atrial myxoma, right, atrial myxoma. Similarly S3, right, S3 is what, sound that is heard during the time of what, turbulence, rapid ventricular filling. It is what, it is overlapping with pericardial order. Similarly there is S4, right, this S4, it is heard what, in pathological conditions, and again there is S1. So this is the sequence of what, the heart sound. So with it I hope we are clear about what, we are clear about our tubercular pericarditis.